So for this lesson, we're going to get into some business principles in athletic training. And there's some more stuff with like options on how to run an athletic training business in the chapter. But really, I'm going to focus here on the ideas of insurance and kind of bridging some of those gaps between athletic training and the rest of healthcare with regards to insurance and insurance payments. So let's go ahead and take a stab at this. So when we look now at business principles, we really need to look at a few different sets of words that tend to be used interchangeably. Right? The first one is this idea of reimbursement versus revenue. And normally when we're talking about business principles, and in this case, we're going to be doing the same sort of thing, we're talking primarily about reimbursement. And this is the act of compensating someone for expenses incurred. And in healthcare, this is the idea of billing insurance companies. So when we think of reimbursement, you're thinking of bringing money in by billing these insurance companies. But in reality, that is just one form of revenue, right? Revenue is much larger than just reimbursement. Revenue includes any form of income that is brought in from different business activities. And so there are lots of different ways to monetize athletic training than just reimbursement. You need to think about everything that you're doing for your organization as being part of their business and their business of, serving their clientele, and in that case, making or saving money. And so whether it's advertisements or providing care or whatever it is, you are doing outreach to the community, both internally and externally, that is part of this business principles. From there, then, that gets into this idea of worth or value. Right? When you think of worth and value, right, these get used fairly interchangeable as well. But worth usually has a monetary component to it, where value does not. And so when you think of both of these as well from a business perspective, you need to think of both the worth and value of your athletic training services to the greater organization. Right? You bring in certain amounts of money, right, as far as either actual reimbursements or revenues, or other forms of monetary advancements for the business as well. But also you need to look at the value of this, and this is much larger and much bigger than just money, right? Things like advertising expenses and word of mouth and positive things like that. These all come into value with that. And so as you think of the value of athletic training, right, in order for athletic training to create more worth for their company, we need to increase the perceived value of athletic trainers. And there are several different ways to go about doing this with that. But the most important is, as we've discussed previously, this movement into healthcare and out of athletics. And part of that is getting your NPI, right? Your National Provider Identification Number. And this is a number that everyone can get, but it gives you a unique number as a healthcare provider for the purposes of identifying yourself as this healthcare provider. And so all athletic trainers should be getting an NPI number. The NPI number is also the very first thing that's required in order for you to bill for your services or get reimbursed for your services. We talked a little bit previously about the need for documentation, and we'll hit that again here as well. But lastly is valuing yourself. Not doing things for below market or for free that other healthcare providers would charge for. This idea of athletic trainers somehow being behooven to the individuals that they serve, whether or not it's allowing themselves to be stood up for treatments or doing things for free that other people would charge for, whether that's covering events or working overtime or anything like that, devalues the profession. So when the first thing to do value is to value yourself and to act like other healthcare providers and not like somebody that literally works for the athlete and has and owes it to this athlete for that. It is a business relationship throughout. That's the entire premise of this system. So moving off of that into the main point for our lesson today. And this is the main point for a few different reasons. One, it's important to have a good understanding of how third-party reimbursement and insurance works, both for the purpose of billing, but also just because this is how your athletes or your patients will be paying their bills, regardless of whether or not you're billing their insurance. They're going to be getting bills associated with their healthcare for other healthcare providers as well. And so understanding and helping athletes and patients understand that, not to mention your own health insurance with that. So in order for third-party reimbursement, and by third-party reimbursement, what you're talking about here is the idea that the consumer pays the insurance company or the insurer, right? And then the insurer pays the provider who gives the treatment to the consumer. So the third payer or the third person is the insurance company, right? Normally you have a two-person transaction where you exchange money directly for goods or services. But now we're involving a third entity, and that is the insurance company. And so in order for that to occur, obviously the patient has to be injured, seek care. You have to be a subscriber of the insurance payer, right? Obviously they have to have a relationship with the insurer that involves the insurer paying for their bills. The healthcare provider also has to be willing to bill the insurance carrier. So as we will see, part of the business of athletic training and healthcare is deciding what type of relationship you will have with different insurance companies. You can be a completely cash operated business model where you don't bill insurance with that. Obviously, that makes it more difficult from the standpoint of people wanting to bill their insurance and not pay themselves, but it is possible to get a certain clientele that you can bill directly. And then finally, the carrier has to be willing to pay the healthcare provider for the services rendered. And this is where athletic training really is at this current point in time. We're struggling to get insurance companies to recognize what we are doing as billable experiences. And so in order to do that, we need to continue to advance the profession of athletic training. And you do that through documentation of functional outcomes as a result of athletic training services. So we need more examples in the literature of athletic trainers providing high quality health care and demonstrating positive outcomes for their patients, because that's what health insurance is all about. Health insurance is designed to promote the health and well-being of the individuals that are subscribers after they sustain an injury or illness. And so in order to do that and to get paid for that, right, you have to demonstrate to the insurance companies that what you do will make their subscribers better. And so we do that through the documentation of functional outcomes. And so all of these functional outcomes, as far as different types of surveys are the most common, but quality of life type assessments that show that these individuals' lives are getting better because of the result of their treatment. And so it's the idea of returning our patients back to pre-injury baseline and showing that we can do that efficiently and effectively. And so once you get to a point where you are now going to consider billing for your services with that, you have different opportunities, and this is really going to be in-network or out-of-network providers. And so this is the idea that insurance companies negotiate with providers to allow them to be in-network. And by in-network, what that means is they're going to pre-negotiate the costs of different services and what they will pay between the insurance company and the provider. And in exchange, they will offer up their subscribers to your clinic. And so the idea here is with in-network providers, oftentimes, as we'll see with insurance, insurance pays differently for in-network and out-of-network providers, and there's an incentive for the subscriber, the patient, to go to in-network providers. As such, part of being that in-network provider means that you have agreed to take some form of discount or what the cap is for that different service. And we'll see that a little bit. The idea that what you bill for is not what you actually receive with it. It's kind of like buying a car from that standpoint, that you submit the sticker price to the insurance company, but the insurance company then counters, and you have the option to either accept that and be part of their in-network or be out of network. And if you're out of network and you're not an in-network provider for any insurance companies, then the benefits of to the subscribers of that network will not really apply to you, and so that individual would have to pay more money to see you than an in-network provider. And so this is where that payment contract for in-network and out-of-network providers come into play, right? Out-of-networks don't have these, but still will negotiate each time that they see a patient of different aspects. But in network, you have pre-negotiated this, and most of them are still on this fee-for-service aspect with this idea of time units, and you will see some of that described in some of the additional videos I'm asking you to watch later on. But there are visits where you can get paid by the insurance company per visit or per case, and those are more like what athletic trainers would do, opposed to billing for every single ultrasound that you would give. You would get a flat rate for each visit that that patient goes to, or a certain amount to take care of all of the rehabilitation needs of that patient, regardless of the number of visits. And you can see how that tends to go closer to what athletic trainers are more used to with that. So once you understand in-network and out-of-network providers, then you have to understand that there are different types of insurance companies and different types of insurance plans. And this has to do with how stringent the in-network versus out-of-network requirements are. And so there are a few different kinds of insurance companies. The two most common that you see as far as the most structural normal is health maintenance organizations, or HMOs, or preferred provider organizations with that. And so with this is somewhat of a continuum between in-network and out-of-network providers. Now, with a health maintenance organization, you have much more predictive out-of-pocket costs because they really only cover in-network providers. And so depending on where and how that goes, it can be a pure contract HMO that says you're only allowed to go to this one specific hospital system or group of doctors. And so that's often problematic with patients that then have kids that go like to college outside of town, where there would not have those providers there. And so in a HMO, it is quite possible that there may be zero coverage for out-of-network, meaning that if you go to an out-of-network provider, the insurance company pays absolutely nothing. And so that makes it very restrictive on who you can see. A preferred provider organization now has a moderate amount of freedom to do with that, right? You're able to manage your own health care a little bit. You can select different providers in network versus out of network a little bit more. The differences in costs, though, are passed on to the patient. In which case, so like the idea of preferred provider is the idea now that if you go to one of their in-network people, then you will have to pay less than if you go to one of their out-of-network, but you still have the ability to go to the out-of-network people if you so choose. But because of that, this out-of-pocket costs, or this OOP that you see there, out-of-pocket costs are what the patient pays for the service opposed to what they pay for the insurance. Those are much more variable because of the differences in pricing structures for each of those than different types of providers. Point of service is somewhere in between with that, and starts to, because of that, you then have this idea of deductibles. And so we'll talk about deductibles a little bit more there, but think of deductible as the amount you have to pay before you even have insurance, right? And so in these high deductible health plans with a health savings account, these are very complicated to understand, but basically what a high deductible health plan with a health savings account is it's two different types of insurance. The first is the high deductible health plan, meaning that until you reach your out-of-pocket maximum, until you reach your deductible, you have basically no insurance. You are responsible for 100% of the medical costs. Now, after that, the insurance company pays for all of it. You then counter that with this idea of a health savings account. And basically, a health savings account is a pre-tax savings account that allows you to spend money on your healthcare needs. And so usually with these high deductible health savings or high deductible health plans with health savings accounts, their premiums are going to be lower, and therefore you put more money into your health savings account instead of into a premium. So think of, instead of having blanket insurance that covers your health care, right, and makes it in there that you pay a certain monthly fee, this is the idea of more pay-as-you-go type aspect, and can be cheaper if you have less overall healthcare costs. Then we get into the more government run organizations, even though workers' comp doesn't necessarily need to be government. It can be private as well. But you have Medicare, Medicaid, and workers' compensation. And Medicare now is for individuals 65 or older. With that, there are different parts, A, B, and C, and Part A is what everyone gets. It's hospital insurance and hospice care. Part B and Part C, people opt into and have differing degrees of privatization. Medicaid now is a federal program administered by the states, and that's important to understand because this is state-run insurance with that. And this is for individuals either with disabilities or fall below certain income limits. But it can be very different between each state, and may or may not provide coverage outside of that state, similar to an HMO with that. But Medicaid, you will have some student athletes that are on Medicaid. That's their insurance that they get through their parents, or that they have because they're out on their own. They're not a dependent of their parents anymore, and get health insurance from the federal government, but administered by the states. Workers' compensation is a specific type of insurance and a specific plan that obviously covers workers if they're injured on the job and has additional requirements with that. And so now we need to continue to dig deeper into these types of insurance to understand them better. And so from here on out with this, right, you're talking about combining multiples of these terms within single plans with that. So the first is primary versus secondary insurance. And so you can purchase a secondary insurance policy, which is an additional insurance policy beyond your normal insurance. Your primary insurance is whatever gets billed and is responsible for claims first. So this is most people's personal health plan. They can then purchase their own secondary insurance that will cover their out-of-pocket costs. Or oftentimes, either schools or colleges or universities purchase secondary insurance for their athletes to cover those costs that come out of pocket. And so you can see here, relatively simple with that. You have a $4,000 hospital stay, right? You have a $3,000 deductible, right? So that's what you would have to pay. And then your insurance pays $1,000. That is your normal primary insurance. But because of having secondary insurance, in this case it says it's Medicaid, right? Medicaid will pay the rest minus the copay that Medicare has. So instead of paying $3,000, your primary insurance pays $1,000, secondary pays $29.50, and you pay $50, right? And so we have primary and secondary insurance. So you saw, and we talked about deductible. The other side of deductible is premium. So when you think of the premium, you need to think of monthly costs. This is how much you pay for your health care. And this is often split between the employer and the employee and comes directly out of your paycheck. So when you think of and look at your benefits package and all that, it will have how much you pay for your health insurance and how much the employer pays, right? And that is just your monthly premium, how much that costs, right? From there, then you are buying a healthcare plan. If you buy a healthcare plan that covers more medical coverage than others, right? Obviously, you pay more for that, right? So you can have medical plans that cover different things, right? Include different aspects. But after the Affordable Care Act, there's been a lot less option within what insurance covers because a lot of that is now mandated by law. Instead, what occurs is you pay a premium, right? And that's how much you pay per month, and that affects your deductible. And if you remember, a deductible is what you as the subscriber are responsible for before the insurance pays anything, right? There are some exceptions with copays, and we'll talk about that, but that becomes intermixed with that. But think of the deductible as what you have to pay first. And the idea with deductibles is, first and foremost, it realigns a little bit the healthcare situation. If you have no deductible, you pay your monthly premium, and you have no deductible, then you can go to the doctor anytime you want, and it costs you the same whether you go 1,000 times or 0 times. Therefore, encouraging you to go to the doctor as much as you want and run up as big of bills as you want. With a deductible, then, if you are responsible for the first part of your health insurance costs, then it will limit the amount of times that you theoretically would go to the doctor. Now, that being the case, right, you don't want to be completely unprotected, so you have a limit on how much you would pay. After you reach that limit, you either have coinsurance or complete coverage depending on the type you have. But the important thing to remember is deductibles and premiums have this inverse relationship. If you pay more upfront in premiums, you can lower your deductible. If you have a higher deductible, you would lower your premiums with that. So think of, like car insurance, right? Because that's something that everybody tries to get cheaper with that. And you have these deductibles. That's basically the same sort of thing you have with insurance in the normal aspects. Again, copays and different things in coinsurance we'll talk about here in a second make it more complicated. But the most important thing to understand is this inverse relationship. So after that now, we have copays, coinsurance, and out-of-pocket maximums. And these are now special considerations within insurance plans that make it a little bit different than just the pure deductible and insurance model. So what a copay is a copay is what you pay for a specific care instance, regardless of the amounts of bill. So depending on your insurance plan, you may have copays for specific things, right? You may have a $30 copay for a physician's office visit, a $100 copay for an ER visit, a $20 copay for a PT visit, right? So in this case, regardless of how much the bill is, you pay that one copay. Now, obviously, with the more you have the option for copays, right, the more you pay in premiums because it, creates this difference in incentives, right? You can also then have co-insurance that, instead of having a true hard cap deductible, in which case, the insurance company now once you reach your deductible, then you have basically free health care, right? So in order to minimize that, what they've come up with to try to keep premiums lower, right, is this idea of coinsurance. So now you have a deductible and you pay 100% of the costs up to the deductible. Then you have coinsurance, which means after that, you pay a percent and the insurance company pays a percent. Most of the time, this is, an 80-20 plan. So if you see an 80-20 plan, that means after you've reached your deductible, you pay, as the subscriber, 20%. The insurance company pays 80%. And then most of these then have an out-of-pocket maximum, right? Meaning once you reach the out-of-pocket maximum, that is the most you would have to pay for a specific year period of time. And it's really important to pay attention to these years because at that year point, regardless of when the injury occurred, it's all about when the treatment is done. So like for myself, I had David, my youngest, was born on Thanksgiving, actually. And so we had all of the medical bills associated with the delivery on 1 year. And so we had to pay our premium with that. We had complications with that as well. So we had to pay our premiums all year like normal. We then paid our deductible, which means we paid the first amount 100%. Then we had coinsurance. And so then we split it with our insurance company until we finally hit our cap of whatever that cap was of our out-of-pocket maximum. But then on January 1st, we got a new year, and David had clubfoot, and so he was getting weekly casts at about, $3,000 a week. And so again, we were responsible for a new deductible, still had to pay premiums all the way through, but now we had a new deductible, new copay, and a new out-of-pocket max. So that's why a lot of surgeries often are scheduled for the end of the year, because once you've reached your deductible or if you've reached your out-of-pocket max, then you do have cheaper health care and you don't have to meet your deductible again. So understand copay, coinsurance, and out-of-pocket maximum. And this all comes together in the explanation of benefits. And so this now is what you as the subscriber would receive. The provider receives something similar with that as far as who pays what the bill is. So let's look at this explanation of benefits. Often there's a cover page and a glossary before that, but this is the nitty-gritty component, and this will help explain some of the different components that we talked about. So first here, you can see on this day of service, right, on the 17th, the individual went to the emergency room. They had a couple of labs run. They got an x-ray, and then they saw the physician, right? Each of these are billed separately with that. This is the difference between now uh, billing per service versus a single visit bill. If you had a single visit bill, right, this would all be billed as one, but for each service, which is most common, this is the bill that they receive. So of that, then, this discount, this means that this company here, that whoever did this, Dr. Wellbeing, right, was an in-network provider for this Cigna provider, and as such, they agreed to bill or receive less than that. So like for this $75 75 or $85 charge for this lab, whatever it is, the insurance company said, nope, we only pay $10. And so by being an in-network provider, they agreed to only accept $10, and they have to write off $75 as lost income. And you can see how much was written off for each of these. And so this is that discount component that's negotiated between the insurance provider and their in-network aspects. You can then see here as well for this second lab, it was not covered by their policy. So for whatever reason, this lab is something that was an exclusion for their policy, so the insurance company pays none of that, and so the bill gets transferred to the individual. You then now get to the covered amount with that. And so this is the balance between the discount and the amount billed. So this is the covered amount. So this is now what we're working with. This is what's billed. This is the discount. This is, if there is any that's not covered. This is now what you're insured for. So this is the new bill, right? This $85 would be billed directly to the patient from the provider, is not covered by the insurance. But this is now the bill. From there, you can see that some of this was applied. They had no co-pays because these aren't round numbers with that, but they did have money left to reach their deductible. And so they had $290.91 before their deductible. So that means they're responsible for that entire component of that $291. Okay? And so once they reach their deductible, then, though, they have coinsurance. And in this case, it's a 90/10 coinsurance. So in that, here's the covered amount. Now they've reached their deductible. So the insurance company pays 90% of the bill, and the patient pays 10% of the bill. So if you add this up with that, so we have the total bill, we have the discount, that gets written off by the provider. We have this $85 that's not going to be covered by the insurance, which would be billed directly from the provider, right? This would be like instead of third-party reimbursement, just two-party reimbursement. Oftentimes, in this case, depending on where that goes, providers may or may not have to write that off, or will try to bill separately, but that becomes problematic with that. But that's another time. But now they have the covered amount, which is there, how much they had to pay, how much the insurance paid, and then what they owe. Now, so of this $782.91 that was billed, the insurance company paid $65.77. The patient paid $298.22 plus $85 if that gets billed, and then $333 is written off by the provider. But now, since this is this is now January, since they have reached their deductible, at this point now they would have their coinsurance. So if they were to do this all over again, now they would not have this deductible. And now of these numbers, coinsurance would immediately come into play, and they would pay 90% of the remainder of their bills regardless with that. So they've reached their deductible, so now they have their coinsurance at 90%. once they reach their out-of-pocket maximum, then they pay nothing anymore. This becomes zero, and their insurance plan pays 100%. So obviously this is fairly complicated with that, but really make sure you understand, you know what each of these terms are and what that means, right? What's the rate payment, right? That's the discount amount. What is a copay and what is a deductible? What is coinsurance? And then finally, the one that's not on here because it gets paid every month is the premium. So know how that works, and that will describe how insurance works, and you can understand that a little bit better. So that's the end of this lesson, a little bit longer than some, but I do want you to spend some time watching the other video as well about how now this works from the provider point of view, how you go about billing for your different services. Again, if you have any questions, let me know, and see you later.